Hello people, this is Dr. Muskaan this side, and today I am going to discuss very beautiful case. It is all about aspirational pneumonia. So let's start the journey of this case and let me tell you how I discovered the diagnosis of aspirational pneumonia, and later there were also some complications. We will discuss the progress of the case further. So here is 47-year-old male who has came to emergency in hospital. He was unconscious and there was altered sensorium present. Chief complaint was blood and vomiting since evening. On arrival, airway was compromised. There were signs of airway obstruction present. On breathing assessment, respiratory rate was 20 per minute. SpO2 was 90% on room air. And when we have applied NRBM, that is non-rebreathing mass, SpO2 comes out to be 99%. So here we have got two findings, that is airway obstruction and your desaturation. Further, on circulation assessment, pulse was 96 per minute and BP was 128 by 88 mmHg. That shows it is normal. Sensorium was unresponsive. GCS was E1, V1, M1. That is GCS was 3 by 15. Bilateral pupil were equal but sluggishly reactive. No eye opening, no verbal response, no motor response. RBS was 213 mg per dl, which is showing us the criteria that falls into diabetes. HOPI, the patient was apparently asymptomatic since evening when he drank alcohol in the birthday party around 500 ml at some place in the Greater Noida. Patient was admitted to Sukanlal Hospital initially, and there he was referred for higher center. And when he has came here in the ER, they inserted central lines, Foley's catheter. Further, patient was shifted to ICU. There was indication of presence of oral bleeding. There were multiple episodes of vomiting with blood-tinged vomitus. Past history: no history of type 2 diabetes mellitus, hypertension, TB contact, epilepsy, thyroid, coronary artery disease, or any other comorbidities. Personal history: he is chronic alcoholic and smoker. He consumes 200 to 300 ml alcohol per day. General examination: decubitus patient was not oriented to time, place and person. Vitals: BP was high, it was 158 by 100 mmHg. Respiratory rate was 30 per minute. SpO2 was 98% on 40% FiO2. ACPVR VC mode. Heart rate was 129 per minute. From this we came to know that patient is hypertensive, there is tachypnea, there is tachycardia, and SpO2 was also not maintained. It was held. There was venti machine that was helping the patient to maintain the SpO2. System examination: CNS examination, GCS was 3 by 15, bilateral pupil sluggishly reactive, reflexes were absent. CVS examination: S1, S2 was heard. Respiratory examination: bilateral Krebs was present in the inframammary region. Per abdomen examination, it was non-tender and it was distended. Investigation picture shows, first of all, let me tell you about ABG. ABG shows respiratory acidosis with cellular injury, ischemia or hypoperfusion. CBC shows leukocytosis and hyperbilirubinemia. USG picture shows grade 1 fatty liver with mild hepatomegaly and calculus cholecystitis. Urine examination was normal. HCV, HIV 1, 2, HBsAg was non-reactive. APTT was normal. Prothrombin time was normal. INR was normal. On chest X-ray, we can see some infiltrates which were present. There was collapse of lung and there was thickened pleura, which is suggestive of aspirational pneumonia. When I calculated shock index, that is heart rate divided by SBP, 128 by 181, it comes out to be 0.7, which is indicative of mild shock, because mild shock comes in the criteria of 0.6 to 1. So hence, from all this history, there is a diagnosis of aspirational pneumonia with sepsis, with septic shock. How come sepsis? SIR calculate kiya, it was hypertensive, it was tachypnic, 2 positive for SIR plus infection because leukocytosis tha, to sepsis. Now, so story ends here because lactate level normal थे and severe sepsis या septic shock में जाने के लिए आपको hypertension चाहिए, lactate levels आपको बढ़े हुए होनी चाहिए, so वो present नहीं थे. Further, chest x-ray में infiltrates जो दिख रहे थे, if you can see from here. और जब आप किसी भी एस्पिरेशनल निमोनिया पेशेंट का चेस्ट सीटी स्कैन देखोगे तो आपको ग्राउंड ग्लास ओपेसिटीज दिखेंगे. नाउ लेट मी टेल यू सम पॉइंट्स अबाउट एस्पिरेशनल निमोनिया एंड सम पॉइंट्स ऑल्सो अबाउट एक्यूट कैल्कुलस कोलिसिस्टाइटिस. So what is aspirational pneumonia? It refers to pulmonary consequence resulting from the entry of endogenous or exogenous substances into the lungs, lower airways instead of stomach. मतलब stomach में जाने के बजाय it is going to the your airways. Now, what are the causes? Endotracheal tube, NG tube, bronchoscopy, endoscopy, altered consciousness, alcohol, drug, GRD, dry mouth, neuromuscular disorders जैसे myasthenia gravis वगैरह. Symptoms क्या क्या होते हैं? Excessive swelling, excessive sweating, rapid heart rate, shortness of breath, cough, fever, fatigue, chest pain, loose discoloration of skin. डायग्नोसिस कैसे बनाएंगे? कभी भी एस्पिरेशनल निमोनिया का बनाना होगा, चेस्ट एक्सरे यूज़ करेंगे जिसमें इन्फिल्ट्रेट प्रेजेंट होंगे अपर या लोअर लोब में, या फिर हम सिटी स्कैन यूज़ करेंगे जिसमें हमें ग्राउंड ग्लास ओपेसिटीज़ मिलेंगी इन द लंग. मैनेजमेंट कैसे करेंगे? इसका मैनेजमेंट बेसिकली एंटीबायोटिक्स के थ्रू ही होता है. द स्टैंडर्ड ट्रीटमेंट फॉर managing the patient of the aspirational pneumonia is penicillin or the clindamycin drug, or other antibiotics which we use are against the gram-negative organism, that is third generation cephalosporin, rosuvastatin, fluoroquinolones यूज़ कर सकते हैं, levaquin या फिर piperacillin, tozomectin. Now, what is acute calculus cholecystitis जो इस पेशेंट में प्रेजेंट है? Actually, I have appreciated almost every symptom of acute calculus cholecystitis in this patient, and it was said that when patient will get stable, we will shift that patient to the OT and we will get the cholecystectomy of this patient done. So, let me tell you what is acute calculus cholecystitis. What it is. It is inflammation of gallbladder. Chief complaints are right upper quadrant pain, nausea and vomiting. On examination, there is Murphy's sign present, that is patient catches her breath when pressed in the right hypochondrium. There is Boa signs present, that is hyperesthesia in the region of the 12th rib. When we give some mild stimulus on the 12th rib, so there is pain at that time also. मतलब बोआ साइन है कि अगर मैं आपको हल्का सा टच कर रही हूँ वो पेन नहीं हो रहा, बट आपको वहाँ पे टच किया जा रहा है एंड आपको फिर भी पेन हो रहा है, बहुत हल्का सा टच पे भी. इन्वेस्टिगेशन पे आपको अल्ट्रासाउंड में मिलेगी इसकी फाइंडिंग एक्यूट कोलिसिस्टाइटिस की. हिडा स्कैन कर सकते हो जिसमें आपको comes in to gallbladder in 30 minutes, come into bowel in 90 minutes, and non-visualization of gallbladder in this case suggests the diagnosis of acute cholecystitis. Management is NPO, IV fluids, IV antibiotics, gram-negative anaerobes, and painkillers. Further, there is Tokyo census guidelines. Grade 1 is mild, does not meet the criteria of 2 and 3. Grade 2 is moderate, WBC is more than 18,000, duration of symptoms is more than 3 days, gangrenous, abscess, erythematous. Grade 3 is more severe, in which there is moderate plus organ dysfunction. If the patient presents the symptoms in 2 to 3 days, like in our case, we have to do emergency cholecystectomy, or we can do lab cholecystectomy, which is safe. And if the patient presents the symptoms more than 3 days, then there is conservative management, discharge, and after 6 weeks there is interval cholecystectomy. So, in my patient, grade 1 Tokyo guidelines were present, right upper quadrant pain, nausea, vomiting was present. It was diagnosed by ultrasound, and management was emergency or laparoscopic cholecystectomy. I hope you have also gained some good points listening to the history of this patient. Further, what was the treatment which is given to this patient? Patient is NPO right now, he is on IV fluids, injection Monosep is given for the treatment of bacterial infections such as pneumonia, injection Pantop is given for GRD, injection clindamycin is given, which is standard treatment for aspirational pneumonia, injection thiamine is given, which is for vitamin B1, which helps to keep the nervous system healthy. Nebulization is given, Dulene and Budecort, which is a treatment for shortness of breath, wheeze and nausea, and injection AMCET is given, which is treatment for nausea, vomiting. Syrup loose is given, which is a treatment for constipation. And that's all. Dr. Muskaan is signing off now.